Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Welcome, everybody, to this session on Patient Insights Illuminated, a rapid-fire dive into CLL and MCL. I'm Lorna Warwick. I'm the CEO of Lymphoma Coalition, which is a global network of patient organizations, and I'm pleased to participate today in this session with Medscape. And joining me as our medical experts, we have Toby Iyer, who's from Oxford University in the UK, and Nicole Lamana, who's from Columbia University in New York. So welcome to them. So in this program, we will discuss some key findings from the 2024 Lymphoma Coalition Global Patient Survey on lymphomas and CLL, and then have discussions with our key experts here on some of these findings and how maybe they can shape future patient-centered care for both chronic lymphocytic leukemia and mantle cell lymphoma. Just a quick introduction to the Global Patient Survey. We do this survey every 2 years. In the even years, it's a survey that's online only. We did the survey in 2024 in 20 languages. The survey is open to patients as well as their care partners, and it gathers survey respondents' perspectives on many topics around their care and what's working for them and where there are some gaps. In the 2024 survey, we had over 11,000 respondents from 79 countries. So we had a great response. For CLL, we had over 2,400 responses, and then for mantle cell, around 380. Out of those, most of the data that I will talk about today is for those that had received treatments. And so for CLL, that's just over 1,200 patients, and 350 of those with MCL have been treated. But before we get into this, we're going to actually meet David. David was diagnosed with CLL after a routine blood test when he was in his 60s, and his disease initially remained a background condition until it progressed in 2013, requiring treatment. So his case exemplifies the importance of long-term, patient-centered care in CLL management, highlighting both the clinical benefits of emerging CLL therapies and the psychosocial impacts that the disease brings with it.
I find it very relaxing to do gardening. You can think about all sorts of things, but it's very rewarding to plant your seeds and then watch them grow, nurture them. At the end of the summer, you're harvesting them all. When I was in my early 60s, I had a routine blood test, and it came out with some anomalies. So they referred me to a hematology doctor to do some further tests. And he did some tests, and I went back for the results. And it was quite amusing because he said, "I've got some good news and bad news." So I said, "What's the bad news?" He said, "You've got CLL." I said, "What's the good news?" He said, "It might not get you, something else might get you first."
It was just something that you accepted, and we just carried on doing everything as normal until it started progressing. So we had years and years and years of it was just a background thing going for blood tests. But
I think it was about 2013. He found that the disease was progressing and needed treatment.
Oh, they were just amazing, absolutely amazing. I mean, nothing was too much trouble. They explained everything, and everything, difficulties we came up against, they helped to sort out as much as they possibly could. They were just very reassuring and a very, very amazing team.
Well, I had a good relationship with all the professionals. They were always very kind. You were never rushed in any consultation. They were willing to answer any questions I asked them, and it was really a pleasant thing, really, to go and see them. Well, I wasn't really involved in any decisions until they got to the stage that it needed treatment. The treatment options are finite. You can do this, that, or the other, and it's up to you to choose. They tend to recommend which treatment options you go on. Just recently, about 2 or 3 years ago, they've put me onto a new derivative of the initial drug, which has meant my atrial fibrillation problems have gone away. I still have the joint problems, but they're constantly doing research and trials. There's numerous trials going on at the moment, and it's a question of when you relapse from a certain drug that they put you on something else.
I did feel that I was part of everything, and yeah, because there were some things that you didn't want him to have and some things that he did want to have. So, you know, we were very active on that front, really.
They gave me some literature to read to understand what the treatment was and what side effects there were. Obviously, the side effects didn't affect everybody, but you were liable to have some side effects. We almost got onto first name terms with some of the professionals. They almost treated you like being part of their family, and they were always anxious to know how you were getting on and what you were able to do or not able to do. Well, it meant that whenever I went, I was really relaxed, and I didn't have any fear of what was going to happen. I was in their safe hands to look after me and obviously prolong my life. I feel very confident that they will look after me for the rest of my life.
Well, as a family, we are going on the journey together.
Gradually, over a period of time, my energy levels have dropped, and I've got very little energy to do much at all at the moment. So it's with great regret that I'm not be able to do my garden at the moment, and I've got to rely on my wife and my daughter and son-in-law to do all the work. But I can still see the benefits of their work.
So first, I would like to get both Nicole and Toby your reflections on that video and what David was able to share, as well as his wife, on their experience today. And Nicole, if you'd like to start, that'd be great.
Yeah, I mean, it's wonderful to see. He obviously had a very good relationship with his care team over time. It sounds like he, was pleased not only with the care, but the fact that they, would always ask him about any symptoms he had and how he was doing overall. And he kind of felt like he was part of their family. And that's what we hope we can give all our patients, that sort of time and energy, so that they all feel like they're getting, their questions answered, but while we're treating them, they know they're in good hands.
I would second that. I was really struck by his description of his care team. I think there was a real emphasis on the sort of longevity of care, his experience over many years. And I think we certainly, recognize this as hematologists, particularly looking after diseases like CLL. You're going to get to know your patients really well, and your relationship with them is really critical for their own experience of their care. So I think, recognizing that and making a real effort to make sure people feel welcomed and that they feel personally looked after, I think is really critical. I think one final thing, he remembered exactly how he was told about the diagnosis some decades earlier. And I think a great reminder to all of us that people remember those initial experiences. And if they're good or bad, they can really set the tone moving forward for the nature of people's experiences in their care.
I agree with both of you. And I will just add to this, even though he says that he's gotten great care, he has a great relationship with his team, and he feels like he can talk to them around issues he has and get his questions answered. He does say he still can't do some things that he loves, right? That he's had to sacrifice being the one out in the garden, digging and planting and taking care of this thing that he loves. And so I think that that's important to note, that even in a situation where the patient is so positive, there's still a cost to this disease, and he's not quite able to live the life that he would like. So we are going to dig into the 2024 Global Patient Survey. And we're going to look at 3 different topics as we move through this. The first topic is going to be shared decision making. Shared decision making is something that we don't actually have a good definition for of what it is. What we can agree on is there are certain steps involved to making shared decision making work. And that involves, a lot of information sharing between the clinician and the patient to make sure everybody understands what the options are, how patient preferences can be impacted or will impact that decision, and then also looking at that decision itself and how it's going to work. So when we were looking at the Global Patient Survey, really we're looking at the behaviors that are happening in clinic that can either contribute to or deter from shared decision making. But ultimately, at first, it's important to know, is this something that patients want to do? And you can see here that in both groups, definitely patients want to be involved in shared decision making and have some kind of role in deciding what's ultimately going to happen in their disease care. For us, what's important to note and interesting to note is the percentage of patients that actually want to make that decision by themselves is increasing. So we see 1 in 5 patients now in 2024 data that says they want to make that final decision themselves. It's about the same percentage as you'll see of people that want to make the doctor to only make the decision. So that's something that really needs to be considered when you're working with your patients in clinic. And then, of course, we ask our patients, did you actually get more than one treatment choice? And this is still a big gap where we see 2/3 of patients are not getting a treatment choice of any kind. They're just being assigned a treatment by their physician. And then we were looking at those that discussion that's happening where the clinician is explaining the pros and cons of any relevant therapy option. And it's like, are patients being able to engage in those discussions? And we looked at it as, are they able to ask questions? Are they getting understandable answers to the questions if they were asked? And of course, here again, we see that this is not always the case. Less than half of our patients feel like they are encouraged to ask questions. And then only about half say that the clinician is actually checking and making sure that any answer that they're providing to their patient addresses their concerns and is presented in an understandable way. And then that other piece, it's hard to have a conversation with someone if they're always interrupting and not allowing you to fully express yourself or finish all of your thoughts. And we see for 2/3 of patients with CLL, they're more likely to say that they are allowed to continue their thoughts without any interruption, but it's just over a half with MCL. So there's room for improvement here in letting your patients fully voice what they have to say. Of course, decision making can happen, or participation in it. Decision making can't happen unless the patient has good information about their disease, about the potential treatments, and other care supports that might be available to them. We did ask patients how informed they feel. Most do feel well or very well informed, which is great. But what's important to note is they are looking for information elsewhere than what is just provided to them in clinic. 90%, 96% of patients in both subtypes here say that they were searching for additional information. It would really help if they were being directed to good sources of information that is relevant to their particular case, because, of course, there's lots of good and bad information that people can find in different public settings. Also, when we're looking at patient preferences and how those are being integrated into discussions, we actually asked the patients what was most important to them about the most recent treatment they'd had. And you can see they talk about an improved or longer survival or bringing about a remission. But also equally important to them was an improved quality of life. So for us, it's just making sure that all of these things are fully delved into when you're having discussions about therapies. That we're not only talking about how long a patient is going to survive, but how well they're going to feel with the treatment, and beyond the treatment, dealing with those long term as well as those short term side effects. As well, when we're looking at patient preferences and clinician support for these deliberations, we did ask, are doctors actually asking our patients questions that are relevant to their quality of life and their well being? And you can see about 40% of patients with CLL and a third with MCL are only saying yes, definitely. So, a ton of room for improvement in the types of questions that are being asked to make sure that our clinicians have a great understanding of the impact of any one treatment on a patient and what's important to them. To counter that, though, it's important to know, our patients being honest when they're asked questions about their side effects and symptoms, or other issues that they might be experiencing. And you can see here that there is some gaps. So this is a CLL only response, but about a quarter of patients are saying that they're not completely honest with their doctor for whatever reason. They're choosing to hold some information back, and that is also counterproductive to having these good conversations. Of course, shared decision making, this whole concept is great, but do patients actually feel like they're involved with these deliberations as much as they want to be? So are they involved as much as they feel they wanted to participate in decisions about their care and treatment? And you can see that most are. So despite the fact that there is room for improvement in shared decision making and practice in the clinic and how those conversations are happening, still for a good portion of patients, they do think that they have some kind of voice, which is important to note, and of course, a positive outcome from this survey. So now I just love to get some faculty reflections on this data that we've presented and your thoughts. Toby, if you could start.
Yeah, thanks, Lorna. I'm really struck by perhaps some of the differences that patients wish for in terms of the way they make decisions around their care. And it clearly isn't a one size sort of fits all approach that's necessary, with 20% wanting the doctor to decide, 20% wanting to decide almost independently, and the rest mostly wanting a sort of collaborative decision. So I suppose listening to that and reflecting on it made me kind of think that I need to do what I can in my clinical practice to identify those preferences for patients. Shared decision making certainly is very, very important in diseases, where people will live a long time. There are multiple options, increasing numbers of options, complexity around the management of care. And so CLL particularly is a very good example of that. And certainly giving patients time wherever possible to consider all options, giving them written information, ensuring caregivers also understand the nature of the different treatment options, for example, available, I think are all important components. The good thing about CLL often is actually you do often have a bit of time to play with when you're starting treatment. And I find that very valuable. It's very useful to give people time to go away, find out the information they wish to, come back, ask more questions, have a further dialogue around therapy, because that can be really helpful in terms of making decisions. But yeah, I think I certainly learned a lot listening to that, and I think it's interesting how different people go about their decision making.
Yeah, when I reflect on this, there's no doubt this is becoming increasingly more complex, not just for patients, but for providers. As Toby alluded to there, with the increasing number of targeted therapies and how we give therapies, particularly for CLL, but even for mantle cell, things are evolving for all the different disease subtypes. And, it's becoming more and more of a longer conversation that we need to have for our patients. And there's no doubt I can see that there are some patients who still would like, more of the input, obviously, for the physician to guide them. And that still exists 20 years of doing this. And you still have those patients that really want the physicians to take the lead. They want to hear it, but they want you to take the lead because it is too overwhelming. And there are patients, of course, who really do research and really want to take that time to dig into the details and bring studies and things and data to the physician and go through that. And then there are patients who are in the middle, and right. So you have this wide range of, obviously, not just patients but providers and how they do this. And it's becoming more complex and difficult. As Toby alluded to, I think the one benefit on some of these diseases that are more chronic in nature, such as CLL, is that it is, rare for us to tell somebody that they not that they need treatment tomorrow for the most part. And so we do have a little bit of extra time. And so I try to set up in my own clinic that we have the conversation more than once, as they're heading to needing treatment sooner, and so that they can kind of go away with the different options, but then come back with questions. And then when they've picked their option, we've actually set up a whole, even another telemedicine visit just to go over all the side effects of their options. As a separate whole hour, with the team, just because we know that sometimes that will change their mind, or they'll reflect on that and figure out how does that fit in with their lifestyle. So, we sometimes that isn't always, I think, depending upon the need and urgency for treatment, that may not always be apparent for all our patients. I think I was a little surprised about the slide that had sort of the fact that patients didn't feel that they were talked to, about half the patients didn't really feel that they were given more than one treatment option. That struck me, I guess, as something new, because I would think now, given all our options, that there would be a discussion that they had more than one treatment option for the most part. So that did strike me as something new. But I think the rest, I kind of figured that we have an opportunity here to do a better job. And it's evolving, and I'll like to even see this data 2 years from now to see how it looks, Lorna, in the future.
And we will give you that opportunity, Nicole, because there's a new survey coming in beginning of 2026. We're going to move a little bit into those patient-centered care practices. This is just asking patients what's important to them around how a doctor communicates in clinic, the type of information. And so you can see here that 97% of our patients are saying that it's very important that the doctor tells the truth about their diagnosis, that they 96% understanding patient caregiver priorities, that they have some information that they can self-manage, and that you're really asking questions about the patient preferences and how much they want to be involved in decisions about their care and treatment. And so why we do this particular or ask this particular question is, we often hear from doctors that they don't want to give too much information because they're worried about overwhelming their patients, or they are worried about being totally honest on what they think prognosis is because they don't want to take away hope. But at the same point in time, we're getting a different opinion back from the patient. So I'd love to hear your thoughts on this.
Yeah, I mean, I totally agree with. There's no doubt that I think that transparency on the communication is really important, and I think this is one thing that we strive to do with our patients. But to be, it sometimes a little complex, because there's no doubt that I think understanding about one's illness is a little bit sometimes complex, and so we often have to share, what it means to have a chronic illness, so we understand where they're coming from, as we're talking about where we're coming from, and what their perception of their own disease is, and what their limitations are, and sort of what they know about their chronic illness. And so I think this is a complex conversation, but absolutely true that we have to sort of be as open as we can, so patients kind of understand what the expectations are, what they're coming from and where they're coming from, so that there's an open dialogue about that. Because as Toby noted before, it's really true that you form a lifelong bond with these patients, because they're following with you as if they're following with your primary care internist, or your in your primary care provider, because you're seeing them over a long period of time. So hopefully that understanding and truth telling about their diagnosis and what they could be anticipating in the future is communicated. So we have more opportunity for sure.
Completely agree with all those points. I'd say, fortunately, more often than not, at least in CLL, you're certainly my experience is initial diagnosis and so forth. We're really maybe debunking some of the language and trying to sort of give people a good understanding of what terminology means and so forth. But often we can be fairly positive about the outlook of things. Certainly later on down the line with patients well, if they're getting to a difficult point in their disease, it can be challenging to, um, you know, break difficult news in terms of their own expectations, partly because the field has evolved so much that um, there's a lot of hope, for example, in CLL that the sort of next new agent will come along and it will sort of bring about sort of more years of potentially good quality of life, etc. Um, but yeah, I mean, it's important to know that people want sort of very truthful information, and that's certainly my experience as well.
Thank you both. We'll just move on a little bit here to looking at these physical and emotional side effects. Um, Obviously, there are things that impact patients more than others. We know most patients are going to have symptoms at some point, and of course, most have side effects from their treatment. You can see here 95% of those with MCL and 90% of those with CLL talked about that they had some kind of side effects. We're focusing this specifically on fatigue, and the reason being that in the survey, time after time, fatigue is listed as the most common symptom, but also the most common side effect of treatment, and something that is often not well managed in clinic. And so you can see there's the percentages here of about 63% in MCL and 66% in CLL had fatigue as a symptom, and again, a little bit higher than 71% MCL had it as a side effect of treatment, and 59% in CLL had it as a side effect. So it can be compounding for patients, and it's often one of the things that isn't as well resolved with treatment. But part of the issue for us is like, are patients actually talking about it? We've seen this again in past surveys that it's not something that they freely discuss. And they're more likely to discuss it when they're newly diagnosed. If they have fatigue as a side effect, they're much less likely to discuss it as they move along their treatment pathway, that they're still really tired or it's affecting their quality of life. Same point in time, but just over half of patients say that those that have fatigue like this say that it has a severe or very severe impact on their quality of life. And so, it's only about a quarter of patients that say that they can freely talk about fatigue as much as they like. 40% are saying to some extent, and then the rest is really just not well addressed for them, which is an issue. And then when we look at the emotional side effects, 83% of those with MCL and 78% of those with CLL said they had some kind of emotional effects that they relate to their lymphoma or CLL in the past 6 months. On the side are the top 5 issues that they reported. So fear, progression, or relapse is the leading emotional issue there for those with MCL. But you can see for CLL, it's actually almost half are concerned about the fact that they're immunocompromised and the impact that that has on their quality of life. At the same point in time, we can see 2/3 of patients with MCL and just over half with CLL said that they did receive some support of some kind or recommendations from their medical team about how to cope. But there's two things that go with that. One, do they actually act on what their doctors have recommended? And about half of the patients that did receive some support did follow through. At the same point in time, though, it's important to note that this is one of those things that patients often don't discuss with their doctors. And when we asked questions around these issues and how well they were communicated, 1/3 of those patients that feel like they have depression did not tell their doctors. People that have extreme fear, like fear of dying. Almost half of them don't tell their doctors about that. Fear of progression is something they're more likely to communicate, where we get about 20% of patients say they don't. So 4 out of 5 patients are actually having those conversations, but there's obviously gaps in communication both ways. So if we can reflect on these a little bit, with some of the issues that we've raised here, what are things that you think that we could do to actually start addressing patients' needs in a different way, and perhaps help them manage or cope with these, whether it's fatigue, whether it's other physical effects, but also the emotional needs that our patients face due to their diagnoses? And Toby.
Yeah, thank you. There's so much in this that you've just mentioned. I mean, the first thing to say is I think our clinic systems that we have, and I can obviously speak for myself, are not really set up well for the physicians to adequately meet the sort of full emotional needs of patients going through, major treatment for significant blood cancers. And so support services around the clinical practice, I think, are really critical, so that all these, really important needs that you mentioned are addressed. So, for example, in the UK, we have specialist nurses who work alongside the physicians. We have psychological medicine support, and also a sort of separate associated charity that is a counselling service as well. So I think all these adjunctive uh, parts of our healthcare provision are really critical. It may be that they feel like their physician can't help them. It may be they feel their physician doesn't have time to, or maybe doesn't have the empathy for it, or could be a whole variety of reasons. But it's clearly really important that we understand this. I feel like kind of that last slide is almost the sort of tip of the iceberg for patients. We see small amounts of what people experience and suffer, actually. And I think as physicians, we need to be more open to these aspects of our patients' care, and actually what really is mattering to them. And I think they're really good examples to reflect on.
Yeah, I wholeheartedly agree. I think this is a complicated issue. In the US, it's even more complicated because depending upon their insurance, they may not always have access to some of these other supportive, psychiatric support, or even other consultations, and it really may be insurance dependent, like a nutritional consult or something else. As Lorna noted, the internet could be great, but it could be really dangerous. And so we tried to actually give them a whole folder in the beginning of, here are reputable places you can look to, websites that have additional support for CLL patients, for example, or mantle cell lymphoma patients, and we have a whole, booklet, but also where they can, websites that they can go to try to, if they're into support groups, if they want something like that nature, if they don't want, not all patients want the same things, of course, either, or are ready for that, because it might be too overwhelming. But we try to supply them with different avenues to go to, and certainly if they, we do actually, if I can refer them to, if I think they need, we talk about whether they want a psychologist or a psychiatrist, and if their insurance is acceptable, we'll make those appropriate recommendations. But you're absolutely correct, Toby. I think that, many of the clinics may not always, can't certainly address all issues. Sometimes we'll also say, are there issues over time we can deal with, right? So that there may not be that we can do everything all at once. But can we address some of these symptoms or issues over more than one visit, so that we can try to, take them by pieces, knowing that the patients are dealing with so much, sometimes, and it's very overwhelming. So I think that we just need to partner better and try to ask these questions with our patients to get a better understanding of what their needs are, so we can better try to support them depending upon what their needs are. So there's lots of opportunity here.
Thank you both for that. A little bit more into that well-being piece that we've been discussing. And this is actually, we asked a question that relates to a validated tool, the EQ5D, and just asking patients in the last month if they had had any of these issues. And you can see almost 70% of those with mantle cell, and just over a half with CLL said that they had some kind of issues, the number one being some loss of strength. the chart underneath the table is asking actually for those people that experience those things, how bad is the impact on their quality of life. They had a 5-point scale they could respond to. And so this is just asking those if it was severe or very severe. And you can see again from a patient perspective that, that inability to do all of the things that they could before they were diagnosed with lymphoma or CLL is really the key issue for most. Though there are, of course, issues for others like that loss of strength, which is impacting the most people. So when we're looking in this, it's like, what can we do to help address the functional limitations and again, the quality of life challenges for our patients beyond the traditional medical treatment? And Toby.
Yeah, that's a great question. Again, I think first of all, we need a really good understanding of some of the nuances with different disease entities. You can see there are some quite key differences, for example, between diseases. And in an era where mantle cell lymphoma is patients are still receiving quite intensive chemotherapy and potentially autologous stem cell transplant, that differs significantly from, for an example, where patients with CLL their first line treatment might be acalabrutinib monotherapy, for example. So, I think the nature of how these different therapies affect people and also affect people clearly over a long period of time is really important. And a whole range of sort of aspects, including mood and fatigue and energy levels and sort of muscle strength and so forth, are clearly all really important here. And this is again where our um, additional sort of allied healthcare professionals really can play a role. Physiotherapy, physical exercise, dietitians, dietetics, etc. A range of other people within our healthcare system can also help some of these aspects, as well as general practitioners. And I think there just needs to be a better education piece around some of these long-term problems that people have here, and probably also giving patients maybe more permission to talk about them in the clinical environment, because I think probably there's for a variety of reasons really probably a limit to which people feel they can talk about their fatigue levels and so forth. Maybe they've had that dismissed in the past by somebody and they don't feel like they can bring it up again, for example, and particularly when people live over a long period of time with a disease. So I think people need to feel empowered to talk about these issues in the first instance, and we need to be managing a lot of these better, I think.
Absolutely correct. It's, this is agreed that sometimes it may be particularly challenging because a particular functional limitation could really be due to either the disease or a side effect of whatever therapy they're on. And so trying to figure that out first is very helpful, because then you might really be, either effectively reducing the type of therapy they're getting, changing the dose, or holding therapy. And we've done that for certain individuals when they've had symptoms that we think are really related to the actual therapy. And sometimes there requires a change. And that's really important. So that dialogue between the patient and the providers is really important. And then pulling in, as Toby alluded to, sort of if these are issues that, despite, maybe not being the therapy per se, or being a more multifactorial sort of functional limitations, then the question is, how do you pull in these other services to help? Whether that be physical therapy, we talk about a lot. We talk about three major things a lot in our clinic has to do with exercise, diet, and sleep hygiene, about sleep. And so then the question is, around these issues, are there things we can help our patients with about, even if they're not, in great shape for real true exercise, but is there minor stuff they can do, small things like walking or getting into a pool where they're buoyant? Is there any of those things? Can we refer them to physical therapy? Even if they're stay-at-home folks because they're older and more frail, so that physical therapy can come to their house. Is there a benefit from a nutrition content or sleep hygiene? Are there other medical problems that might be contributing to their functional limitations in addition to the treatment that they're getting for their lymphoma or leukemia? And so I think, those are, I think it requires an open dialogue, but certainly a sincere dialogue between the patient and the provider, so we can figure out how we can best work together to see if there are things or strategies that we can help patients with, via, for their quality of life issues and challenges that are happening. And there's no doubt this is requires time and time with the patient to understand, letting them sort of communicate. And if they don't feel they can, then that's a problem, right? It's a problem for them, but it's a problem for us. So we need that open dialogue so we can best help them support their needs.
So when we're looking now, just really quickly at the end of this, and we've looked at all this data, is there one action that you're thinking about? I'm going to take this into clinic as we move forward, and just a quick 1 minute reflection from you on what you've heard.
Yeah, I think I'm going to think more about patients' fatigue. It's clearly a major issue for people. I'm going to look to give maybe more time and patients more space to talk about it, proactively ask more about it, and think about ways to improve that in the clinical setting.
Lorna, I always learn something from the surveys. So I'm very happy about that. There's no doubt, I think, despite, always, I think we can always try to improve what we're doing. And so I think one of the things I'm going to take away from this is how to spend a little bit more time, maybe asking about symptoms that maybe we don't always, appreciate from them, or they may feel uncomfortable bringing up. And fatigue is certainly one of them. Although thankfully, I think we do ask a lot about fatigue because it could be related to some of the therapies, but not only fatigue, but just, other issues that they may feel uncomfortable bringing up, and giving them a little bit more time to converse with about issues or questions that they have. And so that they feel that, if there are, sometimes I think we give them a lot of information, and maybe, sometimes that's overwhelming, and they don't, that alone, they don't always provide back from that information what they think is the most important that affects their quality of life. And so I'm going to work on improving that in my clinic.
And if I can add, because I do appreciate very much both of your responses, but that doctor-patient communication is so critical, and allowing patients that opportunity to speak and checking understanding, those pieces are crucial, and just acknowledging as well that those patients' preferences can change over time. The longer they're in treatment, the longer they're coping with their disease, because life is also changing behind the scenes. Their kids are growing up, or someone's getting married, and so their priorities change in their regular life outside of that disease. So those conversations have to keep happening to make sure that you're really dealing with the current situation for your patient. So that would just be my one thing to add to this conversation, other than remember, patient organizations are also an excellent resource for both information and support for your patients. So thank you both for the great discussion. It's always good to have conversations with both of you, and I always appreciate your insights and your dedication that you show to your patients. And as well, thank you to everyone who's watching this, and we appreciate that you participate in this kind of activity. Please continue on to answer the questions that follow and complete the evaluation. It's always important to ensure that we're improving what we do.